Welcome to today's Lunch and Learn. Early detection saves lives. Lung cancer screening essentials. I'm Dr. Steve Reinches, Senior President and CEO of NKC Health. Thank you for joining us. Today we're going to explore why early detection is so important, the cancer screening process, and the types of treatment. Our speaker today is Dr. Ben Fangman, an oncologist and hematologist with NKC Health, Medical Oncology and Hematology. He will share information on screening methods and frequency, as well as who should receive them. Dr. Fangman is a board-certified hematologist and medical oncologist. After earning his medical degree from the University of Kansas School of Medicine, he conducted his internal medicine residency at the University of Texas Southwestern Medical Center, and he also completed his hematology and medical oncology fellowship at MD Anderson Medical Center, where he served as chief fellow. If you have any questions during this presentation, please submit them using the Q&A feature below. We will respond to them at the end of today's discussion. And now, please join me in welcoming Dr. Fangman.
Thank you so much, Dr. Reinches, and thank you to everyone for joining in today. Like you said, I'm going to be discussing why early detection truly does save lives, and why lung cancer screening in particular is so vitally important. So just to give a brief outline of my talk today, we'll be going through first the basics of lung cancer, the risk factors, the symptoms, and then the impact that screening has. Talk about the current screening guidelines, which has changed a little bit over the course of the last several years. Look at the demographics that should be screening, how we are screening, and how often. And then talk a little bit about what does the screening process actually look like. What as a patient should you expect, and how to prepare, and then kind of the follow-up that'll happen, and then potentially treatment afterwards if it's needed. Then we'll discuss specifically the oncologic benefit of early detection and the significantly improved outcomes as it relates to finding cancer at distant stages. Then finally, after the talk, we would be happy to take any questions that anybody has. So, discussing kind of why screening is important. Well, about 50% of lung cancer cases still are diagnosed at what is called an advanced stage, meaning that it is not actually curable at that point. So it means, half of the patients that I'm seeing, unfortunately, we have not found it before it has spread to distant sites, such as the brain, the bones, the liver, other organs. And so because of that, early detection, when things are still curable in the early stages, does improve survival rates. It is potentially curable in that instance. And so by screening patients that are at higher risk, we can detect cancer earlier when it's more treatable and curable. Briefly about the types of lung cancer. Broadly speaking, it's broken down into something called small cell lung cancer and non-small cell lung cancer. Non-small cell is much more common. It includes adenocarcinoma. Sorry, the adenocarcinoma got cut off a little bit by my diagram here. I just wanted to show you kind of the different spots of the lung that you can have. Sorry, spotlight's not working. But anyways, the two most common histologies are adenocarcinoma and squamous cell carcinoma. Squamous cell carcinoma is a little more associated with smoking. Adenocarcinoma can sometimes be found in non-smokers as well. We're actually finding that more and more commonly. Small cell lung cancer is almost exclusively associated with smoking. It's much more aggressive. Thankfully, it's only about 10% of cases, give or take. The reason why we kind of put this in its own category is it grows and spreads very rapidly, so it's treated very differently. And unfortunately, most of the cases that we find of small cell lung cancer are advanced stage at the time of diagnosis. So much of what we're trying to catch is the non-small cell with screening, but there will be times where we will get lucky and catch a small cell early, and we are able to cure those, and we're very thankful in those cases. So what are the symptoms that you should be looking out for? So what I'll tell you is a lot of times patients don't have any symptoms at all, especially when we're catching it early, and that's when we want to catch it. But because patients don't have symptoms early on in many cases, it can contribute to a delayed diagnosis, and that's actually the whole purpose of screening. But when you do have symptoms, a very common one, and I see this unfortunately a lot, is patients that have they're diagnosed with a pneumonia because they went into an urgent care, they get a round of antibiotics and it just never really gets better, and they get like 2-3 rounds of antibiotics and it just keeps getting worse and worse. Finally, they get a CT scan and it's actually cancer. It was thought to be pneumonia on a chest X-ray, but it's actually cancer. That's very common. But anything that's kind of persistent and not going away, whether it's a cough, anytime you have blood in the mucus, like coughing up blood, that can sometimes be from infections, but that should not persist, on the order of a couple of weeks. If it's continuing, that is something that is very concerning. Worsening shortness of breath is another potential symptom. Wheezing, and then worsening fatigue is just something you just feel like you're just wiped out at the end of the day. All of these could be symptoms of lung cancer. Obviously, they can be other things too, but it should prompt you to kind of speak with your doctor. Going into a little bit about the stages of lung cancer. So stage 1, broadly speaking, cancer staging goes in the solid tumors goes basically from 1 to 4. 1 is the best to have. 4 is generally it's metastatic disease and thus not curable. Stage 1 is really how we want to find most of these because the tumor is less than 3 centimeters, the lymph nodes are not involved. Stage 2 just means that either the tumor is larger or it has spread to kind of the really localized lymph nodes to the lung. They're called the hilar lymph nodes. Stage 3 is the tumor has spread to the mediastinal lymph nodes. It's most of the time that's what stage 3, but there also is if the tumor is even larger or it's actually spreading into some of the mediastinal structures. And stage 4 means that unfortunately the cancer has spread to other organs. So whether it's the brain, liver, bones, or it's in the lung lining, which is called the pleura. All of those, unfortunately, are not curable. So we're trying to catch these really in the stage 1, 2, or 3 because those are all potentially curable. Okay, so going into the screening guidelines, who should be screened, how do we screen, and how often? So starting with who. The USPSTF, which is the kind of the governing body for most of our screening guidelines, they've changed this a little bit since actually I was in medical school. So now the guidelines say anybody that's age 50 to 80 that has a significant smoking history, which is defined kind of strictly by 20 pack year. So what does that mean? It's a pack per day is defined as a pack year. So a half a pack a day over 40 years is 20 pack years. So you just multiply. If it's one pack times 20 years, that's 20 pack years. And you have to have quit smoking or still currently smoking within the last 15 years. And the reason why that is because most studies show that your lung cancer risk really reverts back to kind of the average after about 15 years. So that's kind of the rationale for why the USPSTF has come up with these guidelines. They're also based on a couple of clinical trials, one of which read out in 2011, excuse me. The other, I believe, was 2021, both in the New England Journal, that kind of took similar demographics and showed substantial improvements in overall survival with screening these patients. Other kind of high risk, either occupational or otherwise hazards, known exposure to radon, which is very common, unfortunately, here in the Midwest. Any exposure to asbestos, so any construction workers, sailors back in the day. Any personal family history of a cancer is another kind of a loose risk factor. Most patients that have a family history of lung cancer, especially if it was in a smoker, that's not necessarily someone that has to be screened, but someone that is very, very reasonable to. Known history of COPD or pulmonary fibrosis is another very reasonable indication to get screened. Now, most of COPD is caused by smoking, and so that you would kind of fit into both of those categories. And then someone who has a significant secondhand smoke exposure, whether it's both your parents smoked, growing up, your spouse, and in combination with any of these other risk factors, again, reasonable to be screened. What I'd say is most of our screening folks are that first bullet point. They're active smokers or someone who has smoked or quit within the last 15 years. Just a plug, if you're still one of those smokers, the single best thing that you can do for your overall health is to stop smoking. Even if you get diagnosed with a lung cancer, there's a lot of patients that I see that say, well, I already got a lung cancer, what's the point of stopping smoking? There's been many clinical trials that have shown that there's an overall survival benefit with stopping smoking, even at the time of diagnosis of lung cancer. So the types of screening, I would say the one that's used by far and really should be used per the USPSTF recommendations is something called a low-dose CT scan, or colloquially called a CAT scan. Why is this the preferred screening method? One, it's a much lower dose of radiation than a standard CT scan. Some studies show as much as 90% less. The standard is about 20% the radiation. And the reason why this matters is you are going to be doing these actually yearly, and so we want to limit the radiation exposure as much as we possibly can, and these are good enough resolution to detect any nodules that are important to work up further. And this is much more effective, these CAT scans, much more effective than at identifying nodules that are suspicious for lung cancer than a standard chest x-ray. That's actually how these studies were done, was comparing these CT scans to an x-ray, because that's how we actually used to find a lot of these. PET scans aren't used as much for screening. It's typically used if you find a nodule that you're concerned about. What a PET scan uses is basically a radioactive sugar to highlight tumors, and the reason why that works is that tumor cells tend to uptake more glucose because cancer can't really undergo oxidative phosphorylation, which is the main reason, or the main mechanism by which humans, their cells get energy. That's why we breathe. That is why oxygen is so important to us. Well, cancer cells can't really use that, so they uptake a lot of glucose, and so PET scans use that biochemical process to be able to identify things. So that's not really used in screening. It's very important once a diagnosis has been made. When I am seeing the patient as a medical oncologist, it's a very sensitive test to make sure that cancer hasn't spread, or to really get at what might be more suspicious. Okay, so how often should patients be screened? Well, the initial scan's kind of a baseline for all future comparisons. So the radiologist is going to look at, if someone found a nodule, they're going to use that reference point when we look in the future to determine, if there's growth or if it's stable. That's the most important thing. Anything that is not growing is typically not cancer. So essentially, if there's no nodules found on the first scan, we typically do them yearly. That is how the NLST study, that 2011 study that I was talking about, that's how they did it. But if you find a nodule, it just depends on, there's something called the Fleischner criteria to determine how suspicious it looks, to determine whether we need to go straight to a PET scan or a biopsy, versus just follow this up in 3-6 months. So basically, if no nodules are found, it's 12 months. If you find a nodule, you're either going to kind of go down a more thorough diagnostic workup if it's very suspicious, versus a lot of times we're repeating a scan in about 6 months to make sure things aren't growing. So what does the screening process actually look like? So when you're going for a CT scan, one thing that I do think is very important is you don't want to have an active infection when you go for really any CT scan, because like I touched on earlier, a common reason why lung cancer gets missed initially is someone might actually have a pneumonia, and then they get an X-ray and you can't really see the mass because you have a pneumonia. So you actually can have false positives or false negatives, in fact, if you have an active infection. So you want to tell your doctor if you have any signs of a pulmonary infection, fevers, cough, that sort of thing. You will be asked to remove any metal items, jewelry, watches, that sort of thing. You'll have to be in a hospital gown. The CT scan is very quick. It is not like an MRI. If any of you have had that, if you're claustrophobic, that's not something you have to worry about with this. It's a painless, non-invasive test where you'll basically just lie on a table and the scan moves around you. At one point during the scan, you will be asked to kind of hold your breath. What that does is allow us to get the best look of the lungs, because we draw air in. It just inflates those lungs best we can, gives us the best possible look. You shouldn't feel anything during the CT scan. If you do, that is not normal. So how to prepare? It's really pretty simple. Physician orders it. We will take care of making sure that there's insurance coverage. That with the USPSTF making this recommendation, that should never be a concern. We offer these low-dose CT scans every day. In fact, I believe last month we did about 130 of them, of the low-dose scans. And you know, we can ask about any co-pays, but especially for screening, if the USPSTF, this goes for really any screening test that's recommended, a lot of times it's entirely covered, or at least markedly so by any insurer. So what to expect after your scan. So if there's any abnormalities, the radiologist will review, so will the physician that sent you for the scan. So everything will show up in your patient portal. If anything looks suspicious, your doctor's going to call, or set up a follow-up appointment to make sure that any follow-up is getting taken care of. So like I mentioned earlier, small nodules that aren't overly suspicious, usually we follow up within 6 to 12 months, just because it's actually not uncommon in smokers to find nodules. And what I'll tell you is, in the NLST trial, about 26% of these low-dose CT scans, we found a nodule. So about 1 out of 4 times. Even if we did, about 96% of those nodules found actually didn't end up being cancer. So that's what I always tell patients to reassure them, is a lot of times we find things, it's a prior scarring of an infection. It's a prior pneumonia that is scarred off. Not everything that we find is cancer, but it should be followed up to make sure that it's not an early cancer, because if it is, then we need to address it. If a cancer is detected, that's when you'll actually see someone like me, a medical oncologist, or possibly, and usually in conjunction with, either a cardiothoracic surgeon, which here is Dr. Elder, who is wonderful, or a radiation oncologist, which here is Dr. Park. Both of them, along with me, we talk about cases every single week, come up with a consensus on what is the best treatment approach for each individual patient. So what are the benefits from an oncologic standpoint in terms of early detection? I kind of mentioned earlier, the earlier the stage, the better the outcomes. So how do we improve outcomes when we find things early? So what are the treatment options? So this is assuming that we've actually diagnosed cancer. So the first treatment option is surgery. There's a bunch of different types, and I don't want to get too much into the weeds here, but basically you can take as much as just kind of a wedge resection, taking kind of part of the lung, versus taking an entire lobe of the lung, versus taking actually sometimes an entire lung. That's not as common now as it used to be, but that is all kind of parts of the option for surgery. Chemotherapy, what that is an IV medicine that rapidly, kills rapidly dividing cells. That is used typically in conjunction with surgery and or radiation. Radiation, what that is basically high energy beams that precisely target the cancer cells from outside of the body. So we're shooting radiation just to take out the tumor and preserving any of the other structures around it. Other things that you may have heard of, whether it's on an ad on the TV or other patients that have been treated, something called immunotherapy. What does that do? So basically, it's a medicine that helps the immune system do what it's supposed to be doing anyway. So cancer cells actually develop in all of us every single day. What typically happens is your immune system recognizes this is not a cell that's doing what it's supposed to be doing. So your immune system is supposed to basically take care of it and say, this is not a cell that's doing what's supposed to be doing. I'm going to kill it. Cancer cells can kind of put up a flag telling the immune system, I'm a normal cell. So what immunotherapy does is it basically takes that flag down to allow the immune system to recognize the cancer and then ramps up the immune system to basically do what it's supposed to be doing naturally. So it's a totally different medicine than chemotherapy. Targeted therapy. This is a much more new field where we have, because we're doing genetic testing on all of these tumors now to find what is the actual mutation that is driving cancer growth. We have drugs that actually target these specific mutations now. So all of these things are treatment options, and we will be testing people for all of these potential options to make sure that what I tell patients every day is our job is to give you the best chance of cure with the least chance of toxicity. And so we use a combination of some or all of these to give us that best chance. So what are the outcomes? So early stage cancer, like I said, stage 1 to 3 is curable, but early stage, and what I mean by early, so stage 1 cancers often can just be cured with radiation or surgery alone. You don't need chemo, you don't need immunotherapy, you don't need targeted therapy. Those are very good referrals because I know that patients are going to do really well. Some studies as high as a 90% 5-year survival rate, and what that means is, they don't die of anything. A lot of the patients in those studies had other medical comorbidities as well. So the 5-year cancer-specific survival rates are about 95-96% in stage 1 disease. So extremely curable disease. Whereas stage 4 has a 10% 5-year survival rate. Now, that's actually up from 5% about a decade ago. So as the optimist looks at that and says, we have doubled the survival rates in a decade. But that's obviously not what we want. I mean, that's 10% is not enough patients. What we need to do is find these earlier before they become stage 4. And I mentioned that NLST study. What that showed was that the lung cancer screening reduced rates of lung cancer death by 25% and actually decreased all-cause mortality. So, I mean, death from any cause actually by about 6%. And that actually is one of this is the cancer screening that if I had to pick one that has the best overall data, it's actually this in terms of preventing all kinds of death. So it is, when you compare this to even mammography, colonoscopies, cervical cancer screening, all of it, this is one of the best data that we have. And now that's not to say that those other screening tests aren't also extremely important, but this one is easy and it is as effective as anything out there. And so with that, I would be very, very happy to take any questions. I really appreciate your attention and happy to take any questions.
Well, I think that's fascinating. I've practiced medicine for 35 years, and I continue to learn from these lunch and learns. I did not know that the most effective screening test was for lung cancer. That's fascinating. So we have some questions, and I just want to re-emphasize a couple of the very important points that you made. So we have some questions from the audience, and one of those questions is, what are some of the common early warning signs for people who may worry about lung cancer?
Yeah, I mean, I think the one that I see over and over and over again is that, someone who came in, especially to an urgent care, like they didn't go see their PCP, but they're having a cough, they thought they had a pneumonia. They get treated for antibiotics, and it's not going away. That coughing stuff up is just not going away. Sometimes people wait months, to actually kind of go and get further testing. That always bothers me, because sometimes the cancer has then spread to the point where it is not curable. I would say too, a common one that I see is just worsening fatigue. Like, things that you were able to do, maybe you were able to go walk a couple of miles a month ago, and now it's like, man, you're getting winded just even walking down the street. That's a really, really common one. And one that I see too, coughing up blood is a red flag. I mean, that should be worked up in every case. In my opinion, if you're ever coughing up blood, especially with the smoking history, I think you need to get a CT scan to make sure that there's not something else going on.
It's interesting. I have a personal friend, a very healthy, non-smoking female who is of my age, who had a 3-week history of persistent and progressive cough and cancer.
Yeah. So it can even be that quick. I mean, that's especially the non-smokers. That's what concerns me greatly. So most of the time, if it's a non-smoker, not most, it's just more likely in a non-smoker. When I was talking about some of those targeted therapies, a lot of times those do actually have a driver mutation that is driving the cancer growth, whether it's an EGFR mutation, an ALK mutation. There's so many different things now that we have that target these specific mutations. But even, and that's one thing that I do want to reiterate, is that even if you don't have a smoking history, you can still get lung cancer. That's actually a very common misconception. And so it's important that no matter who you are, if you're having any of these symptoms, just kind of thinking in the back of your mind that it's possible. Is it the most likely thing? Probably not, but it certainly merits further workup, for sure.
So take a non-smoker who has a persistent symptom. How do you encourage them to get screened if they're hesitant to get screened?
Yeah, I think particularly in a non-smoker, it can sometimes be hard. But what I mention all the time is that data that I was mentioning, that if we find something in the stage 1 area, so less than 3 centimeters, it is curable in about 90% of cases. Whereas if we find something in the stage 4, it's not curable, and the unfortunately the 5-year survival rate's only about 10%. It's such an easy test to go through that it isn't like, I was kind of, I think it's harder to get people to want to do like a colonoscopy, because you have to do the prep, it's just, and there's a stigma with that. This is very easy. You don't have to prep. You just go in. It's a very quick test, and then you're done. And so to what I was kind of explain is the benefit is so high, and the kind of barrier to actually undergoing the screening test is so low, that if you're having any sort of persistent symptom, or if you have a significant smoking history and you fit into that 50 to 80 with a 20-pack year history, quit within the last 15 years, there's just no good reason not to undergo the screening test. The benefit's too high, risk is so low.
So this is a 2-part question. For the audience, I'd like to walk them through the process. What support services are available to help someone enter into the screening process? That's part 1. The second part is I want to spend a little bit of time on the major investment that NKC Health made in the ion endoluminal biopsy system. But let's start with, what support services do we have? How does a patient contact us to navigate the screening process?
Yeah, we have wonderful navigators that are, I mean, they do the Lord's work, and being able to help us guide someone from screening to, if we find anything, the different services that are needed. So basically, what I would say is the first step is kind of talking to your primary care doctor about it. As soon as they put in the order for the screening test, you will be contacted by our radiology service for scheduling. Once that test is done, the navigators will help if there's anything that needs to be followed up. They will work in conjunction with your primary care doctor and the radiologist and the pulmonologist. Mentioning the ion is, I think, has really changed our ability to safely biopsy some of these nodules with a significantly lower risk of. The only risk really of doing these lung biopsies is pneumothorax, and what that is air in the lung. The ion significantly decreases that risk. And traditionally, some of these very peripheral nodules, meaning things that are a little bit lower in the respiratory tract, those were very difficult to get to with traditional bronchoscopy. But our pulmonologists here are unbelievably good at getting even very, very small nodules that are very peripheral. I've been amazed. I think it's truly top notch. And I've been to some top notch institutions, and I would put the pulmonologist here up against them in being able to get us an accurate diagnosis on very small lesions. In addition to that, I typically prefer a bronchoscopy if I'm ever worried about a particular lesion, because at the same time they'll actually look at the lymph nodes. Just in case this is cancer, we always want to get a sample of those lymph nodes as well. And so basically we have the full gamut of resources, from radiology to pulmonology to surgery to radiation to medical oncology to the navigators to the physical therapist, the occupational therapist, social worker. If you need help with transportation, there's all kinds of things. The whole goal is to eliminate any sort of barrier to make sure that you're getting the care that you need to prevent what kills me every time is someone that could have been screened for the lung cancer, and then we find it when it's metastasized. That's a very difficult conversation.
Our pulmonologists are so excited about this new technology that we brought, that we can diagnose these lung nodules at the earliest stages, so the survival rate is so much better.
Yeah.
Well, thank you, Dr. Fangman. We really appreciate the presentation. We hope the presentation was both informative and helpful. Please join us on August 20th for our next Lunch and Learn, Understanding Radiation Oncology, a community guide to cancer treatment with Dr. John Park. And thank you again for joining us, and have a good afternoon.